Let me get into reference pricing. I think Tom queued it up pretty appropriately. If you look at reference pricing, it's kind of a buzzword in the industry today. Depending on who you talk to, it has a bunch of different meanings. And I think what you're going to see today is a version 2.0 of reference pricing. If I had to characterize the key differences between what HST is doing on reference pricing and the first generation, I would say, was a bit adversarial, legalistic. Second generation of reference pricing is collaborative with the provider community. It's fixed fees. And the reason we have our partner here, MedWatch, is we've developed a pre-pricing Navigator technology that has been a game changer in terms of reference pricing, and we're going to get into that process as well. So without further ado, let's cover the definitions and some of the things that we're talking about. We've been doing this since 2009. Obviously, to get to the point that we are today, we've gone through the school of hard knocks. And when we founded the company, we really had two objectives in mind in terms of how to use this technology and these services. I think the first thing that we saw in the marketplace is that healthcare is a distorted market. Any functioning market, you have ebbs and flows, prices go up and down. Healthcare prices only move in one direction, which is up. So looking to address the market distortion was one of the prime concerns in terms of developing this technology. Secondly, we felt that there was a wrong that needed to be righted in the marketplace. And that wrong was when 62% of household bankruptcies are due to medical expenses. So you work all your life, you accumulate your assets, and at the point in time when you're most likely in your older years to use healthcare, then all of a sudden you get hit with this, this pricing, and a lot of your assets are obviously dissipated. So looking to address those two market distortions and how we can make an impact in the marketplace. Reference pricing, depending on who you talk to, a host of different definitions, a host of approaches. But I think in its simplest form, what we're doing is using published reference databases, cost, price, to establish the value of healthcare. And so again, being able to tie all your numbers back to a cost, a regulatory filing, and have some accountability for the pricing, critical aspect of this. In terms of plans, I think the most common one is the Medicare factor equivalent. So Medicare plus 40, Medicare plus 50. And we learned over the years that that's basically the preferred method because providers are accustomed to their Medicare, their Medicaid reimbursements. They know these numbers. And again, in the spirit of collaboration, if you can say, hey, I'm going to pay you 40, 50, whatever points on top of Medicare, you have a good starting point for some discussions there. RBP health plans. The model that we have is you terminate the hospital component, apply the reference pricing, and then keep a physician component in place. And again, we'll talk about why that's a critical piece in terms of transitioning from PPOs to ultimately where we're going to be talking about is value-based benefits. So reference pricing is the first step moving towards value-based benefits. From there, cost plus. For services that aren't in Medicare, for instance, children's hospitals and things of that nature, at that point in time, you have to revert to cost plus reimbursement for those types of transactions. So again, Medicare allowable pricing is a preferred reimbursement. Secondarily would be a cost plus. And then from there, procedure specific. We've seen probably the most prominent illustration is CalPERS. They started out with knees and hips. Once they were able to reduce their claims cost 20% below what the Anthem PPO contracts were, then they expanded surgical centers, diagnostic testing. I think what's important with that illustration, they represent 1.2 million members, 20% reduction overall on that population, pretty significant. It was obviously recreated in 2013 with those additional services. And coincidentally, we have hundreds of thousands of lives in our platform, and our numbers are tracking very similar to the CalPERS numbers. It's about a 20% reduction overall when you go from a BUCA, Blue United Cigna, Aetna PPO, moving over to a reference pricing model. And then finally, we're going to talk about the consumer component. One thing that did come out of CalPERS is Definitely reference pricing, reduces the claims cost and so on and so forth, but really to maximize the benefits of reference pricing, it's consumer engagement. We're going to talk about a consumer app that we're rolling out to make available so that the tools that Cypress and other partners have in the back room will now be available up front prior to services being rendered to the member as well. As I stated earlier, reference pricing is the starting point moving to value-based benefits. So for the first time, we're actually, when you buy healthcare, what's the cost? What's the price? What do competitors look at in terms of their pricing structure? So changing the dynamics for how we basically do healthcare and establishing a sustainable model. So right now, we have our first generation of quality metrics on our platform. 3 years from now, if Tom's gracious and invites us back, we're gonna be talking about quality metrics, outcomes, case rates, shifting the risk to the provider. So in order to move to the next generation of value-based benefits or value-based reimbursements, reference pricing is the first step in that journey. Any questions? Just very briefly, I'm going to cover these illustrations. I think many of you are familiar with the Time article. Probably the most salient feature here is the Aetna lawsuit. They had members that went to this particular hospital same day. One member got an ultrasound, got charged $60,000. Another Aetna member went to the same hospital same day. They paid $74. I think the key salient element there is that healthcare really is a buyer's beware market. So if you don't have access to these tools, or if you're not utilizing some of this technology, you can bet that you're probably at the $60,000 end of the spectrum for an ultrasound versus about $74. So dramatic effect. The other thing that happened here is when CalPERS was able to achieve those savings results on their population, the market took notice, and SEIU, again, a large trust fund out of California, about 100,000 members. As soon as CalPERS published their results, got their contract rates for the reference pricing, SEIU quickly came back and said, if we don't do something with our membership population, that cost shift is going to come over to us. And so they went and they negotiated an umbrella contract with the California Hospital Association, and they developed a cost-plus model. The important point there is that if you are not using reference pricing tools, not only are you paying inflated prices, but it's more than likely that you're also getting some of the cost shift, because when these providers basically, everybody that's using a reference pricing reimbursement, they're still going to keep their budgets. The difference being is that they're going to pass on those reductions for CalPERS, SEIU, our client base, over to the folks that aren't using reference pricing. Briefly, I'm going to walk you through an illustration. This is actually a de-identified claims analysis. It's from a BUCA for one of our clients. And this really illustrates the pricing and the methodology that we go through. Obviously, we start from billed charges. In this particular case, roughly $88,000 for the billed charges. However, if you look down at the Medicare allowable price, we see that $12,700 is what this facility would accept for this procedure if that individual was 65 or older at Medicare. So you start with $88,000, you're roughly almost 7 times Medicare. At that point in time, when you're 7 times Medicare, I'm going to give you a 58% discount. If I'm setting what the billed charges are, I can give you a 50, 60, 80, 90% discount, depending how inflated it is relative to cost and price. So this particular case, they started roughly 7 times Medicare, the $88,000 versus a $12,700. PPO discount, 58%, reduction of roughly $51,000. However, that still gets them to a roughly $38,000. Again, reference price, $12,700, still paying a lot more than they should for those transactions. At the end, this particular client was reimbursing Medicare at 150%, which came down to $19,000. So this is a blues contract. If you have a PPO contract, you're essentially paying twice what you would under a reference pricing program. And we're going to get into the numbers on the reference pricing, At $19,000, that's a very generous reimbursement for this facility. So let's get into some of the detail. If you look at the two boxes on the bottom, the one on the left, my left, has a Medicare allowable price. So you see here, their Medicare allowable price is $12,700. In order to get some context in terms of cost, price, and value, we looked at, in that county, we found 10 other facilities for the same procedure, and we see that their Medicare price is about $11,000. We also looked at the state, and again, another 10 facilities reported for this procedure, and that's about $11,000. So you see that their pricing is a little higher than the surrounding communities, both in the county and the state. And then you go over to the right and you look at their cost structure. Cost structure, about $14,500. Now, this is interesting because hospitals will have about 10% of their procedures where they'll use it for a loss leader. It could be, in this case, so that they get some recurring revenue from Medicare. Some of it is goodwill for the community. But at the end of the day, as you can see, their Medicare allowable price is less than the cost that they've submitted over to CMS for these services. And then again, we do the same analysis for the other facilities, county, state, and look at the cost structure. And again, as you can see, those facilities, they're $8,000, $9,000. Again, this tends to be a higher cost provider. Now let's go back to the reimbursement. As I indicated, Medicare at 150%, $19,000. So you've got a cost structure of $14,500. You've got a Medicare allowable of $12,700. Medicare at 150 is $19,000. I think we would all be elated if we had that kind of margin on our business. But you can see it's dramatically less than the $38,000 that you would overpay under a PPO contract. Locked in, no right of recourse, you're stuck for the $38,000. So getting all the cost price information and having that level of accountability so that when we do get some of that provider pushback, balanced billing situations, we're in a very good position to defend ourselves. And not only defend ourselves, but we present this information to the hospitals. As you can imagine, first thing the CFO does, pulls his regulatory filing. Do they have the right numbers that I submitted? Once they realize we have the right numbers, then we start to have a discussion. What's a reasonable and fair reimbursement for all parties? I'm going to walk you through a case illustration, and this is a client that we've had over 4 years. You're going to see that there's 3 areas of savings with the reference pricing program: claims, stop loss, access fees, which is great. But the phenomenal thing about this client is they have a 4-year aggregate medical trend of less than 10%. So as you walk in for those renewals and you're getting 5, 10, 20% increases, think about tracking and starting to identify your budgeting and your predictability for benefits to the Medicare medical price index. And that's what these folks have been able to do. It's about a 230 life group, historically with a BUCA relationship. And on the right side, you look at the results. Their PPO claims, 12 months of paid claims history, about 2.8 million. Medicare at 150 gets you down to about 2.5 million, about a $375,000 reduction in terms of claims expense. That claims expense reduction also translates into reduced stop loss. And our stop loss partners, many of which are here, have over the years, come to the realization that any time that you're paying a claim from a cost up basis and looking at this financial information, you're always going to be ahead versus the $88,000 and then trying to claw your way back down to some reasonable reimbursement. So stop loss market is pricing consistently for our block of business 20 to 25% below a BUCA PPO quote. Again, just based on those numbers, if you're going to pay a claim at $38,000 when you could be paying it at $19,000 or less, obviously that's going to get reflected in your stop loss. And then thirdly, the access fees. When you compare the reference pricing arrangements to some of the BUCA access fees, there's some additional and incremental savings there. So three key savings areas that impact the benefit plan. And also, again, having the right stop loss partners that know how to price this and obviously ride out these transactions as they're getting resolved. Any questions? As I indicated, the savings are great, but the most valuable component of reference pricing is managing your medical trend. So think about it when you walk into an employer group. Benefits is one of their top 3 expenses as part of, historically. They have no means of budgeting. We were meeting with the CEO, and he basically said, look, I can do everything right during the course of the year. My operations, my profitability is running great. And he said it was like Stockholm syndrome. I know that in the fourth quarter, this broker is going to come in, and am I going to swallow hard on a 5, 10, 20, 30% increase, whatever that may be, and then I've got to go figure out operationally how I'm going to fund that. Well, with reference pricing and tying your medical trend to Medicare, which runs 1 to 3%, now you have some budgeting predictability that says, with a high level of confidence, we can calculate what our expected planned costs for the following year are. So you change the dynamics for the whole process in terms of, one, how you develop a sustainable reimbursement strategy, but more importantly, how you start to manage your medical trend and tie that over for some budgeting and for some predictability. Any questions? How you pay for reference pricing is critical. Again, if you look at the first generation of reference pricing, a lot of that was billed charges, percent of savings. When you do look at reference pricing, it is a very complex repricing function, but nonetheless, it is a repricing function. And as you can see in this illustration, our model is based on a per employee per month fee, and this compares it to, this was a billed charge. Actually, this is a client that we recently brought on board. But you can see there's about a 90% differential in terms of the fee structure, PEPM versus percent of savings, bill charges, whatever those models may be. It was interesting when we secured this group. Milliman had done an analysis, and one of the conclusions they came back with is that reference pricing works. It does reduce the cost. How you pay for it is dramatic. Under the billed charges percent of savings model, 80 to 90% of the benefits for reference pricing accrue to the vendors versus the plan. And so Milliman said, hey, there's a lot of changes that you're going through to impact the reference pricing program. But if you're not buying it properly, you may not want to you waste your time on that. So how you buy the reference pricing services and the methods and processes that everybody goes through, they're different, but they are significant in terms of impacting your clients and the balance billing and some of the pushback issues that come in. A little over a year ago, we started talking to MedWatch, utilization management organization owned by Harvard Pilgrim. So again, they understand providers, they understand managing unit cost. This has been the biggest game changer in terms of our ability to deliver reference pricing, and then again, to get any kind of pushback less than 2%. Why? Under this model, the pre-pricing navigator gets into the integration of a pricing estimate with the actual traditional pre-authorization. Now, as simple as everybody thinks that, hey, that should be a pretty simple, easy process, I can tell you it took us close to 3 years to find a partner that got it, understood it, and that could affect this. Because think about it, one of the functions of a nurse navigator is potentially redirecting the care if the provider is not going to accept the reference price. And so with that, I'm going to turn it over to Cindy to go through the program components.
What I thought would be helpful is if I just go through the process of pre-cert prior authorization, and you'll see it's a very simple, nothing new for the employees to do. And as Ed was saying, I think the real game changer, and we've done reference-based pricing for about 4 years with other TPAs, and we did not have the luxury of using the pre-pricing navigator. So this has really helped our processing and really being able to deliver a very smooth, easy, customer service friendly type of program. So this is a flow chart about the pre-cert process. And we all know, and I'm a nurse and I've done pre-certs back in the 80s. Every hospital calls for pre-cert. They know it, they do it. And we always like to have people call in for their elective procedures 7 to 10 days prior to admission. And there's a reason for that. And before, it used to be just in case something was denied or needed to be appealed or go to physician review. But now, in this context, we like people to call earlier, because if there is that little pushback, we have a window of time and cushion. So again, the pre-cert comes in, hospitals call, we take the typical diagnosis, treatment plan, date of admission, and all the clinical information that we would do anyways, right? So within 24 hours, of course, we're going to call that physician back, talk to them. We use Milliman guidelines. We're triple URAC accredited. So we're following everything that we normally would to look at medical necessity, level of care, and length of stay. So once we've established that and the case is approved, and we're not just going to approve, the whole stay. Again, just like pre-cert, you initially approve and then you do extensions as needed. Once we approve that case and it's pre-certified, the staff at MedWatch, we have a dedicated team, because we know this is different and this type of program requires a lot of advocacy. You heard Adam talk about when you have reference-based pricing, you really need to have that hand-holding, that support. So we have a SWAT team, so to speak. The team accesses health services technology pre-pricing Navigator. We go into it. We already have the code because we know what type of procedure when they're requesting the pre-cert. Punch that into the system, and out comes the actual dollar reimbursement amount that will be embedded in the pre-cert letter. And that goes out that night. So again, the facility is getting this information pre-service, pre-admission. And that's really the difference of how we manage this process. So the letters are sent, and 98% of the time we don't hear a thing. We're still going to continue. I get this question a lot. Well, what happens to complications in the hospital, infections, and all that stuff can happen. But because we're doing the utilization review, we're following those cases. We're calling up to get the clinical information and the updates. Has this person needed an extension of stay? What's the clinical reasons? So every time we're doing that extension of care, we're also accessing the portal, the pre-pricing Navigator, and getting that updated. So again, pre-cert letters go out, the facility knows what they're going to be reimbursed on. So let's look at the right side, because this happens too. Sometimes criteria isn't met. So standard process with pre-certification is Milliman guidelines, criteria is not met. So now we're going to send that case to physician review. We have a panel of over 30 physicians and access to other IROs. So we send the case to physician review, and if it's not approved, we're just going to go through our standard appeals process as we normally would, okay? A lot of times, though, when we call, we're able to get the additional clinical information so that we can approve that case. Same process again, we just approve it and use the HST program. So the Nurse Navigator Redirection, let's talk about that a little bit. We might get a call that someone read the pre-cert letter, they see the dollar amount, and they're like, we're not going to take 140. And that's what we usually suggest, because that's like the comfort least noise rate at 140%. So when we get those calls at MedWatch, and we are 24/7, we will route those calls, soft transfer immediately, and also give the 800 number to Health Services Technologies Patient Advocacy Center. So when they get that little bit of pushback from the provider, then it's HST's team that's actually going to reach out to the provider to negotiate that claim. So the partners that we work with have already given HST MedWatch the approval to go from 140 up to 200%. Because the deal is you want to close out that claim, and we don't want any balance billing. So sometimes children's hospitals or some other hospitals that are a little bit tougher to deal with, they'll take 160, they'll take 170, but they don't want that 140. So HST will quickly negotiate that claim. And what I love, the story that Ed tells, is that the people that he has on his staff that are doing the negotiating, closing out these claims, used to be on the other side of they used to be on the dark side, so they used to work at the hospital. So they know what these hospitals will take, right? So let's look on the left side here. So the case is successfully negotiated between that 140 to 200%, already pre-authorized with the TPA as part of our contract. We get the sign-off, there's no balance billing. We get that information back, we send out that pre-cert letter so that, again, the facilities know that now they're going to be reimbursed at whatever it might be, 160, 170, or maybe even 180, okay? And again, I can't say this enough, it's great to have reference-based pricing, but what you really need to have is good care management. You need to have a company that's going to manage, monitor, and measure, and that's what we do. And so we follow these cases concurrently, and on the right-hand side, and this happens less than 1% of the time, so maybe HST can't negotiate because it's a hospital that's just like going to tell us to go pound sand. Forget it. We're not going to take it, right? Part of the customer service and advocacy is that we want to help the members understand, the employees understand what their plan pays. But it's always going to be their decision of where they want to go. So if they, in fact, choose to go to that facility that tells us to go pound sand, and maybe in this particular case, they wouldn't negotiate. We'll just handhold that member and we'll tell them, you can certainly still go to facility A, but just you might want to make some financial provisions because you may be balance billed. But at that point, we've educated and we've really supported. We've tried to redirect them to facilities using the pre-pricing Navigator. What facilities in their geographical area that will take the RBP? That will just take it and then they are fully explained that there won't be any balance billing. But again, it's always up to the patient as to where they want to go. This happens less than 1%. I just want to make that clear. Any questions? Am I talking too fast? I'm kind of nervous. All right, just as a recap here with MedWatch's Nurse Navigator, it's really been a game changer because it's just something different, and it's really, you guys know, everyone's talking about it. So we're delivering integrated fully with our pre-cert. We're telling the provider what the expected reimbursement is prior to rendering the care. So if you can take anything away, just remember that. We are giving the RBP reimbursement rate prior to care, prior to admission, and that is a big game changer. It's integrated with our medical management, so we're doing pre-certification, and this is for all hospital services, so inpatient, outpatient, UB, is it 40, 80? UB something, claims. So we're not doing this for doctors' offices, it's hospital-based, inpatient and outpatient. Open access to choose any facilities, full transparency and reimbursements are tied to Medicare cost information. Because of the medical management, and we know most of these folks up here too that are coming up, MedWatch was founded originally by an MGU, so we definitely do things a little bit differently when we're managing the care. But it's a very collaborative, provider-friendly approach. And I think that's a big difference of how we deliver this type of program to your members. I think probably what we are proud about is that we really take a lot of time with implementation and marketing and really helping you help your employers understand what this means and how to make it smooth and really have a very thoughtful implementation program and plan in place before you roll this out, because it's new, it's different, right? And again, supporting the PCP network, we like to encourage using PHCS or First Health as a provider network. Keep that physician network in play. I think people are, they're tight with their doctors and they want to keep that relationship. One thing else I probably want to mention is people are probably thinking, well, what do you do with emergency admissions? 90% of hospital admissions are elective, but you're going to have those emergency admissions, right? So now what happens? So basically what happens, as far as pre-cert is concerned, you all know that we like to have people call after an emergency admission 24 to 48 hours after they've been admitted. So they've been admitted, and what we'll do is we'll just handle that case. We're not going to, have people call for pre-cert for an emergency, of course. But the claim then is submitted, and it's repriced on the back end. Does that make sense? Thank you.